Hello dear students, today we will see about the histology of the upper and the lower respiratory tract. By the end of this session, you will be able to explain the histology related to the pharynx and larynx, explain the histology of the trachea, explain the histology of the tertiary bronchi, histology of the lung, and also we will look into the applied histology of the respiratory tract. The respiratory tract is divided into upper respiratory and lower respiratory. It has the olfactory region within the nose, in the roof of the nose. Anteriorly is the vestibule, and this is the respiratory region. Here the air enters, and then through the posterior nares it enters into the nasopharynx. Then it enters into the oropharynx. From there the air has to enter into the larynx and then into the trachea. Whereas the oropharynx is common for both the respiratory tract and the oral cavity. There are two portions, which is called as the conducting portion and respiratory portion. So the upper respiratory tract is the conducting portion, which has different parts like nasal cavity, pharynx and larynx. The main function of the conducting portion is to help in the passage of the air, and it humidifies the inspired air. Whereas the respiratory portion is also known as the lower respiratory tract, which consists of respiratory bronchioles, the alveolar ducts, alveolar sacs, alveoli, and there is exchange of oxygen and carbon dioxide which occurs here, and it is called as the functional unit. So the general structure of the conducting portion consists of, the respiratory tract consists of four coats, namely, first is the mucosa. The epithelial lining of the mucosa is pseudostratified ciliated columnar cells with goblet cells and lamina propria. The next layer is called as the submucosa, below the mucosa, which consists of loose connective tissue with mixed glands. Then comes the cartilage layer, which has hyaline cartilage, and also we can see smooth muscle. And the last layer is the adventitia, which is the layer of fibroelastic connective tissue. So there are four coats: mucosa, submucosa, cartilage layer and adventitia. Let's see in the next diagram. The first layer, which is the mucosa, consists of pseudostratified columnar epithelium. So you can see that these cells are called as pseudostratified because the nucleus lie at different levels. It gives the eye an appearance of multiple layer, and it has cilia. These cells also have cilia. There are these empty cells which are called as goblet cells present here. Below the this layer is the lamina propria. This is the lamina propria over here, and below the mucosa is the submucosa, which consists of glands, various types of glands over here. The serous gland can be seen here. Below the submucosa is the cartilage layer. So you also have cartilage, and sometimes you also have the smooth muscle. The last layer is the adventitia, which has fibroelastic tissue, which is filled with neurovascular structure. So you have blood vessels and nerves over here. Next, seeing a close view of the respiratory epithelium, which consists of the pseudostratified ciliated columnar epithelium with goblet cells. So what are the cells which we see here? So the ciliated columnar cells, which are most in number, these are the ciliated columnar cells, and they have cilia which beats towards the pharynx. The goblet cells, these are the empty looking goblet cells, which are flask shaped cells, and they are unicellular mucus secreting cells. Unicellular glands which are mucus secreting cells. Then you have brush cells. Okay, you can see a few brush cells. These are columnar cells with microvilli and it has a specific function of sensory function. Then the basal cells, these are very short cells, triangular cells which are close to the base. They do not reach the top layer. Okay, the basal cells are small pyramidal cells, they do not reach the surface. Then there are granule cells which are small round cells with cytoplasmic granules, and they form the APID system, that is amine precursor uptake decarboxy system. So this is about the respiratory epithelium. We can see the epithelium. So this is the cells, ciliated columnar cells which you are seeing here. These are the goblet cells, empty looking cells. Now if you see any short cells, these are the basal cells. Okay, so below this layer is the lamina propria, and then we are supposed to look for the submucosa. Okay, further lining of the pharynx and the larynx. So the nasopharynx is lined with pseudostratified columnar epithelium. The oropharynx and laryngopharynx has non-keratinized stratified squamous epithelium. The larynx has ciliated pseudostratified columnar epithelium, whereas the vocal cords, which undergo regular strain during voice production, it has stratified squamous epithelium. Okay, here it is larynx has ciliated pseudostratified columnar epithelium. Vocal cords are different with stratified squamous epithelium. Next, coming to trachea. So the trachea extends from C6, cervical 6, till T4. Then there is a bifurcation, thoracic 4, which is at the angle of Louis. And what we see is it's made up of 15 to 20 tracheal rings. If you take a cross section, you can see the tracheal ring, a C-shaped tracheal ring, which is bounded behind by the trachealis muscle. Here you can see that it's cut and shown to you how the trachealis muscle is present posteriorly, close relation with the esophagus. So the trachea is a flexible fibroelastic cartilaginous tube made up of 15 to 20 C-shaped hyaline cartilage. The reason we have hyaline cartilage is to keep the lumen patent so that the lumen does not collapse, and we have regularly air entering into the lungs. The posterior end is joined by smooth muscle, which is called as trachealis muscle, and the fibroelastic ligament. The ligament prevents the lumen over distension, so does not allow the lumen to over distend. The ligament prevents it, and the muscle helps in contraction during coughing. So during coughing we need to contract, and trachealis muscle is helpful in contraction during coughing. Further, the trachea is made up of 4 cords. Same, the mucosa composed of epithelium, the respiratory epithelium, and lamina propria fibroelastic vascular connective tissue with elastic fibers. The submucosa has mixed glands. The cartilage and the smooth muscle layer has C-shaped hyaline cartilage with smooth muscle and fibroelastic ligament, and adventitia has fibroelastic connective tissue with neurovascular structure. So we can see the inner lining. This is the mucosa with pseudostratified ciliated columnar cells with goblet cells. Just below that we have the lamina propria, and then we have submucosa with the serous glands. The next third layer is the hyaline cartilage, and we just saw the hyaline cartilage is C-shaped hyaline cartilage. Posteriorly it is bound by the trachealis muscle, and the fourth layer is the adventitia. So again we can see the same view under histology under H&E stain. So the inner layer will be the mucosa, the epithelial layer, that is the pseudostratified ciliated columnar epithelium. Below that is lamina propria. This is the hyaline cartilage which you are seeing very beautiful under the microscope, and the outer layer is the adventitia, and posteriorly it is bound by the trachealis muscle over here. Next, further the trachea divides into the bronchus at the T4 level. It's called as principal bronchus or the primary bronchus, and then it further divides into secondary bronchus. The secondary bronchus further divides into tertiary bronchus, and then the tertiary bronchus further gives the bronchiole or the terminal bronchiole, which further gives respiratory bronchiole. The respiratory bronchiole then gives the alveolar duct. You have alveolar duct. From the alveolar duct you have alveolar sac, and then inside the sac you have the alveoli. They look like a bunch of grapes. Okay, they can also be called as acinus. So here I just want to tell you that the primary bronchus, it has like two parts, we can say. If it is outside the lung, it's called extrapulmonary bronchus, and if it is inside the lung, it is called as intrapulmonary bronchus. So now we can see the difference between all these parts. The trachea and the extrapulmonary bronchus has the epithelium the same, pseudostratified ciliated columnar epithelium with goblet cells. The lamina propria has elastic fibers, lymphatics, ducts of the glands. The intrapulmonary bronchus has a similar epithelium, okay, pseudostratified ciliated columnar with goblet cells, but the lumen has folds. It has folds due to the muscle between the cartilage and the mucous membrane. We can see it in the upcoming slide. So there are folds due to the muscle between the cartilage and the mucous membrane. Lamina propria also is similar, like the trachea. It has smooth muscle fibers here. There is lots of smooth muscle fibers. If you come to terminal bronchiole, the epithelium has changed. Now it has become simple cuboidal cells. There is no cilia and there is no goblet cells. The lamina propria has smooth muscle fibers. It is less connective tissue. The respiratory bronchiole also has cuboidal cells, and here we can see the epithelium is continuous with the alveoli. The lamina propria has more of smooth muscle and elastic fibers, and there are no ducts, we can see. Here the alveoli is made up of continuous simple squamous cells, and in the lamina propria we can notice interalveolar septae, which contains capillaries and different types of cells. What about glands? We can see in trachea and extrapulmonary bronchus there is mucus serous acini between the mucous membrane and the cartilage. In intrapulmonary bronchus also there is mucus and serous acini between the muscle and the cartilage. Here there is, and rest of them don't have any glands. What about hyaline cartilage? Here it is C-shaped in trachea. Here there are many irregular plates. It means that the hyaline cartilage is broken down and there is no more cartilage from terminal bronchiole till the alveoli. What about muscle? Here it's present posteriorly as the trachealis muscle. Here it is a complete layer, but it is above the submucosa with elastic fibers. Here in terminal bronchiole it is well defined muscle with elastic fibers. The respiratory bronchiole has muscle layer with only elastic fibers. In alveoli you cannot see any muscle. Learn this slide very well so that you can understand the upcoming diagrams. The intrapulmonary bronchus, which is also the secondary and the tertiary bronchus, has mucosa, the same epithelium, pseudostratified epithelium with few goblet cells. Lamina propria is rich with elastic fibers. The speciality that the mucosa has folds with the contraction of underlying smooth muscle. The next will be the smooth muscle layer. Then you have submucosa with few seromucous glands. The cartilage and the adventitia, the hyaline cartilage, is discontinuous. So we can see in the diagram, this is the epithelial lining, which will be the same pseudostratified columnar epithelium with few goblet cells, And next you can see that here it is thrown into folds. This is the meaning of thrown into folds. The reason why it's thrown into folds, just below this layer in the submucosa, okay, like here you can see that there is smooth muscle. There is smooth muscle, okay, like between the submucosa and the mucosa, this layer, there is a smooth muscle layer over here. So this is causing the contraction, and that's why the folds are appearing. So it gives a star-shaped lumen. Then in the submucosa you can still see a few serous glands. What about the cartilage? Look at the cartilage. It is not continuous like C-shaped. It is broken down, and this is called as hyaline cartilage in plates. So they're like small islands, you know, like this, they cut down. And the last layer, outermost layer, which will be the adventitia. That's the intrapulmonary bronchus. So another histological picture, you can see the epithelial lining, which is the same pseudostratified ciliated columnar epithelium. Then you have smooth muscle, the dark pink which you're seeing here. These are the smooth muscle, and due to the presence of these smooth muscle, it has caused the folds. Next you can see the mucosa. It's not very clear with any glands. Below that is the hyaline cartilage. Here the hyaline cartilage in plates. Hyaline cartilage is not continuous, it is broken, it's in plates. This is the section of the intrapulmonary bronchus. Next we see the terminal bronchiole. So in terminal bronchiole, now the epithelium has changed into simple cuboidal epithelium, okay, and this is the lamina propria. This now there is a thick layer of the smooth muscle. It's gone round, and there is absence of cartilage. There is no cartilage and no adventitia over here. So next, the terminal bronchiole is formed by the division of the tertiary bronchi. Each bronchiole enters the pulmonary lobule, where it divides to form 5 to 7 terminal bronchioles. The diameter is less than 1 millimeter. It is simple cuboidal epithelium with clara cells. So we have a new type of cells. What do these cells do? They secrete secretory surfactant and glycoprotein, which is the airway epithelial lining. So also they serve as progenitor cells for ciliated and secretory epithelial cells. It protects the bronchiolar lining against oxidative pollutants and inflammation. So they are quite important. They secrete secretory surfactant and glycoprotein, and also they serve as progenitor cells for both ciliated and secretory epithelial cells, and they protect the lining against oxidative pollutants and inflammation. So we saw that there is thick smooth muscle layers. They are under the control of vagus nerve, which helps in bronchoconstriction, and sympathetic nerve, which causes bronchodilation. So this place you can remember, like when you have a bronchial asthma, there is bronchoconstriction, and then we give pharmacotherapic drugs which cause bronchodilation. Next, the respiratory bronchiole. So what is the change here? We can see the epithelium is the same simple cuboidal epithelium, and now this epithelium has continued into the alveoli. It has continued into the alveoli outpocketings. So it is, the alveoli is lined with simple squamous epithelium, and outer layer you have lamina propria here, and you have the outer layer which is the same smooth muscle. Okay, so the speciality that the epithelial layer will continue into the alveolus, okay, outpocketings, outpouchings. So this is the alveoli. It is a single layer thickness, simple squamous epithelium. So the respiratory bronchiole is the continuation of the terminal bronchiole. Simple cuboidal epithelium has alveoli as outpouchings. The alveoli is lined with simple cuboidal epithelium. The ciliated cuboidal cells with clara cells and smooth muscle and elastic fibers can be seen. Distally, it's continuing as alveolar ducts. So we can see that if you have cells with cilia and there are other cells which without cilia. These are the Clara cells. These are the Clara cells, and we learned the importance of the Clara cells. They are progenitor cells for both ciliated cells as well as the non-ciliated cells. And here again we can see the trachea, the primary bronchus here, then this is the intrapulmonary bronchus, secondary, tertiary, and then you have terminal bronchiole, then comes the respiratory bronchiole. So respiratory bronchiole, the lining, you can see that there are ciliated cells and there are non-ciliated cells. The Clara cell is a non-ciliated cell which acts as a progenitor cell. Here again you can see both the ciliated and the non-ciliated cell. This is also the basal cell and the neuroendocrine, that is the apid cells. Okay, moving on. This is a section where you can see all this is the alveolus. These are the different alveoli, single squamous layer, and this is a blood vessel which you're seeing here. This is a terminal bronchiole. As the layer is continuous, you can see here. If you see that it is entering into the alveolus, that means this will be a respiratory bronchiole. It's a respiratory bronchiole. So what is a pulmonary lobule? Defined as a lung unit distal to the respiratory bronchioles. So the alveoli are sac-like structures. The alveoli in a lobule of a lung can be seen here. Here you have the terminal bronchiole, and then you have the respiratory bronchiole in which it is continuing into these alveoli. Further you can see the alveolar duct, and then the alveolar sacs and alveoli. Here we can see the alveolar ducts. These are the alveolar ducts. Then there are a few respiratory bronchiole we can see because it's continuing into the alveoli, and this is the beginning of the terminal bronchiole over here. So the terminal bronchiole, alveolar duct, and then is going down into the alveolar sac. These long ones are alveolar sac, okay, and the small circles which you are seeing here, the grape-like structures, they are the alveoli, and the lining pleura will be the visceral pleura. So what is alveolar duct? It arises from the respiratory bronchiole. It is lined by squamous epithelial cells. The alveolar ducts open into the atria, which communicate with the alveolar sac and the alveoli. So we can see that this is the respiratory bronchiole. It's very clear. So you can see the simple cuboidal epithelium, and then it is continuing into the alveolar sacs. Okay, so here you can see the outpouchings. So this is the respiratory bronchiole. From the respiratory bronchiole you can see alveolar duct. These are alveolar ducts if it's long, and then from the alveolar ducts you can see small projection. These will be the alveolar sacs, and small circles which you see will be the alveoli. So this is the normal lung tissue. You should be able to identify the normal, so that when you see a pathological lesion, this normal architecture is lost. Again, a very beautiful diagram to show you how the respiratory epithelium. This is the division of the primary bronchus here. Then you have the you can see that there is the respiratory bronchiole over here. So here it's the terminal bronchiole. This is the terminal bronchiole, and then it has continued. And here the simple cuboidal epithelium is continuous with the alveolus. Okay, we're seeing it from the outside, alveolus. And what are these fibers outside? These are the elastic fibers which is bounding the alveolus. Then also outer interaction with the capillary bed, both by the arteries and the veins. So this is the branch of the pulmonary vein. You can see that it is branching here, and then this is the capillary bed which is also around the alveolus. We will see it in the upcoming slides. And inner structure, we can see the alveolar duct. Okay, and we can see the alveolar duct continuing as the alveoli further, and you can see small openings. Okay, these openings are called as pores of Kuhn. We will be seeing details about it. and then you have the interlobular septae over here, closely covered with the visceral pleural cavity, then the parietal pleura outside. So there is also the lymphatics around it. Lymphatic vessels can also be seen here. Now the alveoli, it forms the main parenchyma of the lung. So the parenchyma is the actual tissue which does the function, which does the gas exchange. So that is the alveoli, that is the parenchyma of the lung. The sac-like evaginations present at the terminal part of the bronchial tree. So these sac-like evaginations responsible for gas exchange between the air and the blood. It has a spongy texture and a honeycomb appearance. Okay, tightly packed, one side opens into the alveolar sac. So as you can see that these are the openings which are called pores of Kohn, through which is opening into the alveolar sac, and they also communicate with each other. Alveoli separated by the interalveolar septum. So between each alveoli there is an interalveolar septum. So this is basically connective tissue, right? Interalveolar septum between two alveoli. It contains capillaries, reticular and elastic fibers, fibroblasts, mast cells and macrophages. Okay, so interalveolar septum, very important. It contains capillaries, as you can see here, the veins and the arteries, arterioles and the venules. Then you have the fibers, the reticular fibers and the elastic fibers. You have cells like fibroblast, mast cells and macrophages. Next, we can see a beautiful schematic diagram of the alveolus. So this is the alveolus which contains air. This is another alveolus and this is another alveolus, okay, which is lined with we said simple squamous epithelium. So we'll see more details about it. Now one alveolus can communicate with another alveolus through the alveolar pore. So through this it can communicate with each other. It basically tries to equalize the pressure. Now what is separating one alveolus from another alveolus is the interalveolar septum. Interalveolar septum. The interalveolar septum consists of capillaries. So these were the arterioles and the venules which are present here. This is bringing basically the deoxygenated blood, okay, and then there is going to be exchange of gas, like you've brought by inspiration. There is oxygen present here, and that is going to enter here into the capillaries, and then the capillaries are going to give out the carbon dioxide into the alveolus, and that is going to be expired out. Okay, other than that we have the this is another capillary here. So the capillary is also made up of endothelium, which is also simple squamous epithelium. We also have macrophages. Then we said there is fibroblasts, fibrocyte. There are elastic fibers and reticular fibers. Now the lining of the alveolus is made up of two types of cells. It's called type 1 pneumocyte or alveolar cell, and type 2 pneumocyte or alveolar cell. So the interalveolar septum, the alveolar pores in the septum help in the passage of air from one alveolus to another, equalizing the pressure. The elastic fibers help the alveoli to expand during inspiration and passively contract during expiration. The reticular fibers prevent the over-distension of the alveoli. Now the capillary are lined with continuous endothelium. The alveolar macrophages, these are also called as dust cells. They are derived from the monocytes. The cytoplasm of the macrophages contain phagocytosed inhaled carbon and dust particles passed on by the pneumocyte 1. So what happens is the air which is taken inside along with the dust particles, along with the carbon particles, okay, it will be passed on to pneumocyte 1, and then from pneumocyte 1 it will go into the alveolar macrophages, which is present in the interalveolar septum. Further, what happens, the alveolar macrophage will further migrate from the septum and it's carried to the pharynx through the sputum. So let me explain. Now the air is coming here with the carbon particles and dust particles. It is taken up by the type 1 pneumocyte. Now from type 1 pneumocyte, it will transfer it to the macrophage. Now this macrophage, once it's loaded, what happens is it will again migrate back into the alveolus, and then it will be traveling into the pharynx, and it comes out as the sputum. So we can see the epithelial lining here, and this is the macrophage over here. It's also called as dust cells. Alveolar macrophages called as dust cells, and it's derived from monocytes. Now there is a term which is called as pulmonary interstitium. What is it? So the interstitial compartment is the area of the lung between the alveolar epithelium, alveolar epithelial lining, which we saw pneumocyte 1, pneumocyte 2, and the capillary endothelial basement membranes. Okay, so if you see, this is the alveolar type 1 cells, okay, and then the capillary. So in between them there is a pulmonary interstitial layer. So usually in the anatomy textbooks or the histological textbooks, you will never see them marking it as the interstitium. The interstitium becomes evident during pathological conditions. So you have interstitial lung diseases. This is a whole topic in which you should understand the concept of what is a pulmonary interstitium and what problems you will have when you will study this in pathology in the topic interstitial lung disease. So further, moving on to lining of epithelium of the alveolus, which is type 1 pneumocyte, also called as alveolar cells or squamous epithelial cells. It covers 97% of the alveolar surface. It helps in the absorption of surfactant, and it forms the blood-air barrier. Type 2 pneumocyte, also called as great alveolar cells, and these are the septal cells. They are cuboidal in shape. There is about 2 to 3 cells between the type 1 cell. It covers only 3% of the cell of the surface. It has microvilli. It contains lipoprotein. When released, spreads on the alveolar surface, forming the pulmonary surfactant. It lowers the surface tension. It prevents the alveoli from collapsing during expiration. The surfactant also has bactericidal properties. It's constantly renewed, removed by type 1 pneumocyte and the macrophages. So here we can see type 1 pneumocyte, which is about 97% and helps in absorption of the surfactant and forms the blood-air barrier, whereas type 2 pneumocyte is only about 3% and it forms the pulmonary surfactant. It also has bactericidal properties. Coming to the applied histology, Immotile cilia syndrome, also called as cartilaginous syndrome. Here, the ciliary movement of the respiratory epithelium is affected, causing respiratory tract infections. So the term is Immotile cilia syndrome. And when it is seen in male patients, they suffer also from infertility, absence of the protein dynein present in the cilia and the flagella responsible for the spermatozoal motility. So the patient will come to the clinic with infertility and he will have repeated respiratory tract infections. Then you need to think about Immotile cilia syndrome or cartilaginous syndrome. Another applied aspect we can see is the bronchoalveolar lavage, also called as BAL, B-A-L, bronchoalveolar washing diagnostic method of the lower respiratory tract. Here the bronchoscope is passed inside, like we have learned endoscope for the GIT. This is bronchoscope, which enters into the trachea and then into the bronchus. Then the fluid is introduced and then it is collected back for examination. So in pathological conditions like pneumonia or in COVID-19, it was more sensitive than the nasal swabs, and it's more confirmatory. Okay. Further applied histology we can see with asthma, in which you have bronchospasm, that is contraction of the smooth muscle. It is treated with epinephrine, which helps in relaxation of the smooth muscle. Emphysema, the lung alveoli is enlarged. There is destruction of the interalveolar septum, and there is lack of synthesis of elastic fibers, and this is the reason why the alveoli undergo enlargement. Then squamous metaplasia, the mucosa which we learnt is exposed to irritants like pollutants and smoking. It causes change of the pseudostratified ciliated columnar epithelium into the stratified squamous epithelium, and this can further lead to squamous cell carcinoma. Let's look into what happens to the lungs during COVID-19 infection. The virus infects or injures the alveolar epithelium diffusely, results in markedly impaired gas exchange and respiratory failure. So there is diffuse alveolar damage, and there is ARDS. The full form is acute respiratory distress syndrome. As you can see in this diagram, that there is the alveolar damage which has occurred here. There is death or apoptosis or dysfunction, which leads to decrease in surfactant and increase in atelectasis. Atelectasis is collapse of the alveoli. Then you have AT2 progenitors have reduced, which causes the decrease of the AT1 cells. Then also it has increased the inflammation, and the immune cell influx increased, and then the capillary leak is happening here. This is due to the diffuse alveolar damage and acute respiratory distress syndrome. So what happens to the fate of an infected alveolar epithelial cell? It is apoptosis. Furthermore, it also causes vascular endothelial changes, in which you can see venous thromboembolic disease and pulmonary microvascular thrombosis. So here in the blood vessel, it has caused thrombosis, extravasation, and endothelial cell dysfunction. So you can see extravasation of all these megakaryocytes, the neutrophils, macrophages, all this has come out, and there is platelet complement activation, increasing thrombosis. The ACE angiotensin ATR1 axis overactivation, which causes capillary leak, increasing capillary leak, which again increases inflammation. This overactivation has caused vasoconstriction and increased fibrosis and increased inflammation. So the macrovascular injury related to the SARS COVID-19 you can see here. There is venous thromboembolic disease and pulmonary microvascular thrombosis. So when they did autopsy studies in COVID-19 patients, they saw congested lungs with patchy distribution of abnormalities on gross examination. Microscopic findings included diffuse alveolar damage, it's called DAD, diffuse alveolar damage with hyaline membrane formation, pneumocyte activation, microvascular thrombi, lymphocytic inflammation, and proteinaceous edema. These were the references and the textbooks which were used. If you are breathing, please thank a tree, and also remember the COVID-19 situation in which all of us suffered. And if you had a healthy lung and you were able to breathe well, you need to really thank your lungs. Also, you would have heard that the patients who smoked had difficulty in recovery. So all smoking also causes fatal lung cancer. So if you do not smoke and keep yourself healthy, you have chances of a good life without any respiratory infections and complications. So do not kill yourself knowingly. Allah is Merciful unto you.